Hey, welcome to today's Health and Wellness Thursday. I'm happy to have our guest speaker today, Lauren Rudichuk, who's going to be talking about what's new in breast cancer genetics. And I want to acknowledge the Ken Johnson family, who has sponsored much of our patient education resources in memory of Joan Brierton Johnson. So I am Dr. Rebecca Crane-Okada. I will be your moderator today. I'm the clinical program manager for the Breast Center, and our co-host is Alston Novak, who will be monitoring the chat. And if you don't want to ask questions out loud, you may put them in the chat. And again, we are recording this, so please refrain from speaking your name or physician's name. And this will live on YouTube, so you can watch it at any time. So this month, we're so grateful to have Lauren Rudichuk, who is our genetic counseling supervisor from the Center for Clinical Genetics and Genomics for Providence Health and Services, all of Southern California. And we're fortunate to have her with us here in the Breast Center on a regular basis. And Lauren will be speaking today about what's new in breast cancer genetics. So take it away, Lauren.
All right. Thank you, Becky, and thank you, Alston. So I just want to give a quick shout out to our local genetics team at St. John's. So Dr. Ora Gordon is our medical director and medical geneticist for our program. Kim Childers is the regional manager for our program. Then we have myself and Molly Frankel, who is one of our senior genetic counselors who also sees patients at the Breast Center at St. John's. We also have a very big team up in Burbank at the Disney Family Cancer Center and see patients down in Torrance as well, and just have some contact information there at the bottom. So today, just as a brief outline, what I want to review is some Cancer Genetics 101 and hereditary breast cancer. Just want to set the stage a little bit and then spend most of the time talking about some common questions and case examples to help illustrate some updates in the world of hereditary breast cancer. So updating genetic testing and testing criteria, as well as some new management guidelines. And then talking a little bit about unaffected individuals and how risk models and things like SNP testing for polygenic risk scores, the new area of medicine that can help us better personalize risk. So just going to go over the causes of cancer. So when we think about cancer, most cancer is what we call sporadic. That means it kind of happens by chance or randomly in one individual. Often aging is the biggest risk factor, as well as we can have other environmental or lifestyle risk factors. And then sometimes cancer can be what we call familial, about 20% of the time. And also there's this category called hereditary risk, about 5 to 10% of cancers. So to discuss this a little bit further, on the left-hand side, you can see the sporadic cancer family history. Again, this might be one individual, kind of typical age of onset of cancer. We don't typically recommend hereditary cancer genetic testing for people like this, but this is a very evolving field, and so kind of rapidly changing, and we are doing kind of expanding our testing criteria for indications. This middle picture here is this familial cancer history. So this is where we might see a little bit more cancer than we might expect based off of, chance or statistics. We often still see sort of average ages of onset for the cancers in the family. And this is kind of the shared sort of genetics and environmental component where we might have some similar lifestyle or environmental risk factors in the family, but also maybe some smaller inherited risk as well. And then kind of a classic hereditary cancer family history is on the right-hand side. This is where you're seeing things like multiple generations affected with cancer. We often see earlier onset cancer, so usually under 50. People can have bilateral cancer, so like bilateral breast cancer, or cancer in more than one organ system, like colon and uterine cancer. We see less common cancers, such as pancreatic or ovarian. And so this is, again, what we might expect for this hereditary risk of cancer. So we often might say things like all cancer is genetic, but most cancer is not hereditary. So really what I mean by that is kind of illustrated through this picture here. So for people who have a sporadic cancer, again, not due to any inherited risk of cancer, we typically start out with kind of 2 normal working copies of every gene in our body, and you get one from one parent and one from the other parent. And what can happen is over time, from just the process of aging, again, environment, lifestyle, you can acquire a mutation or a harmful change in one copy of a particular gene in one cell in your body. And then again, over time, we can acquire a second mutation in the other copy of that gene. And then if this is a gene that normally helps to protect us from getting cancer, if we have a mutation in both copies, we kind of lose that protection and the cell can start to divide more quickly out of control and develop into a cancer. More mutations have to happen in other genes for that progression, but this is kind of the sort of molecular underpinning of most cancers. Compare that to people who have an inherited or hereditary risk of cancer. They're already starting out with a mutation in one copy of an important gene in their body in every cell. So this is, again, why we often see earlier onset cancers and multiple cancers, because they only require that second kind of required second hit in the other copy to develop a cancer. So how is genetic testing done? So when I'm talking about sort of genetic testing throughout this presentation, it's really referring to this inherited risk of cancer. So I'm not really talking about the genetic testing that can be done on someone's tumor cells. That's sort of a whole different area. That's sort of somatic tumor-based testing that can often be done to help guide treatment recommendations. But this is looking for a more inherited risk of why maybe someone developed that cancer in the first place and also still could have some treatment implications. So this is where we get a blood or saliva sample from someone. We send it to a laboratory. They analyze the DNA of the certain genes in the body and to see if there are any mutations or harmful genetic changes present in the DNA that was, passed down from a parent that indicates there's this inherited risk of cancer. This is often covered by most insurances if you meet criteria for testing, including things like Medi-Cal and Medicare. But if it's not covered by insurance or if you don't meet the criteria, then the cost has really come down over time. And we're looking at often around $250 for hereditary cancer testing through commercial laboratories. So BRCA1 and BRCA2 are the two most well-known genes related to hereditary breast and ovarian cancer and the most common cause. These are mutations in these genes are present in the population, sort of general pan-ethnic population, and about 1 in 400 individuals. But there are certain populations where the frequency is much higher, the Ashkenazi Jewish population being one of those, with a risk of about 1 in 40. So individuals who carry a mutation in one of these, in BRCA1 or BRCA2, can have significantly elevated risks of cancer in terms of ovarian and breast cancer, as well as secondary breast cancers. And we can also see risks as well for things like pancreatic cancer, male breast cancer, prostate cancer, and melanoma. So kind of setting the stage, I want to go through now a little bit, a few questions that patients often ask us or, might be asking on their providers regarding genetic testing. So a common question we get is, I already tested negative for BRCA1 or 2. Should I have more genetic testing? My answer there is really always yes, because BRCA1 and 2 are not the only genes out there that are associated with hereditary or familial breast cancer risk. So there are other high risk, but often rare genes, things like PALB2, STK11, there's some listed there. Then we have more moderate risk breast cancer genes, such as CHEK2 and ATM. We have some newer limited evidence genes, and a lot of this is still unfortunately unknown. But nowadays, when we do testing, we will do multi-gene panels. So we'll look at multiple hereditary cancer risk genes at the same time, often more than one kind of organ system. So if someone has breast cancer, we'll often sort of expand the testing beyond that to look at genes also related to hereditary colon cancer, uterine cancer as well, because they might have a mutation in a different cancer susceptibility gene that could still impact them, their family members, risk and management. Another question that might be asked is, I wasn't offered genetic testing when I was first diagnosed with breast cancer 10 years ago, but now I'm being offered testing by my provider. What has changed? And so really what's changed over time is that our criteria have changed and our guidelines for who should be offered genetic testing for hereditary cancer. And as we learn more about these genes and, what they're associated with and the risks in the population, our guidelines are expanding and becoming less restrictive. So here I just listed the current guidelines for NCCN, which is kind of our gold standard guideline that we use for genetics. I'm not going to go through all of these here, but this is possibly why someone maybe wasn't offered testing, 10 years ago, but now with the expanding criteria, they do meet the criteria for testing and are being offered it. I'll just make a quick mention at the bottom. There is also sort of a new category that is consider genetic testing as opposed to kind of recommend, so maybe less strong indication, but things like breast cancer diagnosed 65 and younger is now a consider category for testing, as well as someone who has Ashkenazi Jewish ancestry, regardless of personal or family history, just based off of that chance alone that they have a higher chance of having a mutation. And I will mention as well that the American Society of Breast Surgeons guideline does recommend at least offering testing to all women diagnosed or all individuals diagnosed with breast cancer, kind of regardless of other factors. Again, insurance isn't necessarily covered in those cases, but something to be aware of, that there's different criteria, different guidelines out there. Another very common question to get is things like, I had testing through 23andMe. Do I need further testing? So this is always a yes. Not all genetic tests are created equal. So something really important to note. 23andMe, is, a lot of people may be aware, is a direct-to-consumer lab that does offer tests for kind of ancestry, but also some health risks as well. They do include the BRCA1 and 2 genes, but they only test for a small subset of mutations in those genes. So it does not include full sequencing of these genes. It also doesn't look at the many other hereditary breast, ovarian, or other cancer risk genes. If someone's positive, we still recommend that they confirm this through a clinical lab, because it could be a false positive. And then the more kind of flip side concerning part is that people can have false reassurance with a negative result, saying, oh, I had it, I'm done, I'm good. But this is not the same thing as clinical grade genetic testing. Another question we might get is, I have a mutation in a hereditary breast cancer gene, and I already had genetic counseling 10 years ago. So should I meet with a genetic counselor again? It's been many years since someone's stepped foot in a genetics office. They think it's kind of a one and done thing and they don't need to come back. But I would say yes to this, because management guidelines can change over time. So for example, these are some recent updates to the guidelines for mutation carriers. For individuals with a mutation in the ATM, which is a moderate risk breast gene, and BRCA2, more of a high risk gene, these genes are also associated with pancreatic cancer risk. And the new guidelines recommend that anyone who has a mutation in these genes, regardless of their family history, consider pancreatic cancer screening starting at age 50, or if there's family history, then doing it 10 years younger. We used to restrict this more to individuals who had the family history of pancreatic cancer in addition to the mutation, but now, again, guidelines and criteria are expanding. So this is why you want to keep in touch with your local genetic counselor, genetics clinic, because things can change over time. And then on the flip side, a gene like CHEK2, we used to think was associated with moderate risk of colon cancer in addition to breast cancer. The guidelines have also changed there, and we're now suggesting that there really isn't an elevated risk beyond general population for colon cancer, or not enough data to support that. And so now we're no longer recommending more frequent or earlier colonoscopies for CHEK2 carriers, where in the past we were. So we're kind of taking away a screening recommendation that we used to have, unless someone's family history changes that recommendation. Another question is, a lot of people are often worried about their family members when they get diagnosed with cancer themselves. They kind of think, I'm taking care of myself now, but what does this mean for my children, my siblings, other people in my family? So someone might say, I was diagnosed with breast cancer at 45, a little bit younger than we kind of average. And my sister was diagnosed at 50, but we both tested negative for the hereditary breast cancer gene. So what is the risk of breast cancer for my daughter? When should she start screening? So this is where we're looking at doing risk models, which are statistical models that help to incorporate various risk factors for breast cancer and then help us to more personalize someone's risk. So these risk models can account for things like genetic risk factors, lifestyle, hormonal risk factors, reproductive, and family history. And they might provide risk estimates for breast cancer, whether those are short-term risks, like 5 or 10-year risks, or longer lifetime risks. And again, with a purpose to help personalize someone's risk and help to guide their management. So Tyrer-Cuzick risk model is one of the well-known risk models that is often used in genetics clinics and also used at many breast centers. Our breast center being one of them. We actually have something called a CARE program. So if you've had mammograms at our breast center, you might have filled out our CARE questionnaire before, which asks you these personal and family history questions to help determine, one, if you meet criteria for genetic testing, but also two, what is your lifetime breast cancer risk if you haven't already been diagnosed with that cancer yourself. So it takes into account these variety of risk factors. Again, I'm not going to go through all of them here. I'll kind of illustrate it through an example on the next page, but different risk models, again, use different risk factors. But this is considered one of the more comprehensive risk models. So this is, again, going back to that individual who was saying that they had breast cancer at 45 and their sister with breast cancer at 50, and then they're worried about their daughter. So if their daughter comes in for genetic counseling, and they want to know what is their risk, we would then talk about whether or not they needed hereditary cancer risk testing. In this case, since their mom and aunt were already tested and were negative, there's nothing on the dad's side. There's probably not really a major indication to do hereditary cancer testing, although some people still pursue it as sort of a general population thing, because there's always a small possibility that there is a mutation from dad's side, even without a cancer history there. But again, not a very high likelihood of this. So what we would do, though, in cases like this is run a risk model. So this individual, they're 35 years old, put in some average risk factors for them. So they had their first period at age 13, first live birth was 30, height and weight 5'8", 150 pounds, and premenopausal. So this individual, we ran the Tyrer-Cuzick risk model for their 5-year risk, coming out about 0.96, so not elevated enough to warrant any changes there, but the lifetime risk is 33.92%. We don't like to use decimal places usually because it's never that precise, these risk estimates. We like to think of them kind of just general numbers. But why this is important is we're helping to use these numbers to help guide us in terms of the screening recommendations. So there's various societies out there and different groups that have different screening recommendations. So it is a little bit nuanced of, I guess, what guideline that you're using. But generally speaking, a lot of the societies say that if someone has over a 20 to maybe 25% chance of breast cancer in their lifetime, based off of risk models like Tyrer-Cuzick that account for family history and other various risk factors, that they should consider enhanced breast cancer screening, which means annual breast MRI, in addition to their annual mammogram. So that would be the recommendation for this individual here, is doing both mammogram and breast MRI, and we typically would alternate those every 6 months. The age to begin screening, again, can vary depending on the different guideline or society that you're looking at. But oftentimes we'll use the sort of 10 years before the earliest diagnosis in the family. So with mom being diagnosed at 45, this individual could start at 35. Some other criteria say starting as early as 30, maybe as early as 25 for MRI. That's a little bit more aggressive, I would say. But this is where you want to have a discussion with a healthcare provider about pros and cons of screening, what age to start, and kind of take it from there. So now just to show you quickly how we can, if it's a slightly different scenario with different risk factors, how the risk can change. So somewhat similar scenario, this person's a little bit older, they're 40. Their mom had breast cancer a little bit older at 55 as opposed to 45, and had breast cancer at 70. But then a couple other differences in the risk factors. So the age of first period was age 16, a little bit later, and had a first live birth at age 27, so a little bit younger. So those things actually help to bring down the risk of breast cancer. Some of the other things are the same, premenopausal, same height and weight, but now we're incorporating density into the model. So when someone is 40 or older, we can incorporate density into the risk model. We know that individuals who have less dense breast tissue have a lower risk of breast cancer compared to those who have more dense breast tissue. It also makes it harder to see things on mammogram with more density, but it's also a risk factor for breast cancer. So this individual's lifetime breast cancer risk in this case is 16.8%. Again, compared to average, which is about 12%. That's sort of where we start baseline average risk in the US. So 16%, a little bit higher, but not enough to warrant, at least in this case, additional surveillance with MRI, and not based off of the density either. So people might also ask, are there other genetic tests available to further personalize my risk? So this is kind of in the same scenario of someone who's unaffected, doesn't have cancer themselves, but trying to look at what else can be done to help understand their risk. So this is where we get into talking about SNP testing. So what are SNPs? SNPs are what we call single nucleotide polymorphism. These are little changes in the DNA that are kind of present in the population. So let's say most people have a letter of the DNA G at one location, and some part of the population has letter T at that location. So that's a SNP, just a small change. Well, these SNPs have no meaning at all, but researchers have found certain SNPs that are associated with certain diseases or health conditions in the population. So for example, for breast cancer, we've identified this grouping of currently there's 313 SNPs that are associated with breast cancer. So each SNP may raise your breast cancer risk by a very, very, very tiny amount, not enough to make any significant change. But if we look at a bunch of these all together, we can have a better understanding of someone's overall inherited risk of breast cancer, kind of separate from mutations in genes like BRCA1 and BRCA2, for example. So we combine all this, looking at all these SNPs throughout the DNA together into something called a polygenic risk score. So most of the population will have an average polygenic risk score, but you have people kind of on their tail end of that curve in the middle, where some people have a high polygenic risk score, more of these breast-related SNPs, and some people have fewer, less breast-related SNPs, or maybe some protective SNPs. And so that can better help us identify who has some elevated risk of breast cancer versus not. And it's another kind of data point to input into these risk models, kind of looking at all of this information collectively. So polygenic risk scores are currently clinically available for a variety of health conditions. Most of the research has really been being done on breast cancer, and it's still an ongoing area of active research. It's not kind of widely used everywhere, I would say, but it's becoming more adopted by many genetics clinics. And we're looking at it for mutation carriers as well. So we clinically have it available for CHEK2 carriers to help us better understand where their risk is on that continuum. And we're looking at it as well for other mutations such as BRCA1 and 2. So this is just a quick example. I know I'm kind of running tight on time here, so I'll try to go through this part quickly. But an example of a clinically available genetic test through a lab that can look at both your underlying, germline testing for things like BRCA1 and 2 and the other hereditary breast, ovarian, other cancerous genes. They can also then do the polygenic risk score. So on the left-hand side, this is someone who maybe before doing the genetic testing, we estimated their lifetime breast cancer risk to be about 20% for the thyroid risk model. But then we do the polygenic risk score. Their score is 0.7, which is a little bit of a lower risk. So that data gets calculated within this model and resulting in this integrated risk, combining all these factors, of about 14%. So this individual we'd recommend routine screening for. On the other side, you have someone who's kind of starting out with that similar lifetime breast cancer risk, 20%, so right around that threshold of deciding MRI or not. They have a little bit of a higher polygenic risk score, 1.7, and then an integrated score or lifetime risk of 31%. So this is an individual then we would have considering doing both mammograms and breast MRIs. So last question I'm just going to finish up with is someone might say, I have a mutation in a hereditary breast cancer gene, but why are my management recommendations different from what I'm reading online? Or maybe what a different friend of mine has the same mutation or mutation in the same gene and they're doing something different. So this is really just to highlight that not all changes or mutations within the same gene are associated with the same level of risk. And that's why personalized risk assessment is really important. Risk can really depend on your specific genetic variant that you carry and other factors such as family history. So lastly, there were some updates kind of regarding this in the NCCN guidelines again. So carriers of genetic variants in the CHEK2 gene, specific variants in this gene, are actually associated with a lower risk of breast cancer. I mean, still more than the general population, but lower compared to other mutations or variants in the CHEK2 gene. So these specific variants now is kind of not enough to warrant changes to someone's management. We have to kind of take this into account along with other factors such as family history, or maybe again, in this case, a polygenic risk score would be helpful. So sometimes it's not the variant alone, but kind of collectively looking at all these risk factors. The NCCN guidelines also now call out a specific variant in the BRCA1 gene that actually has, again, higher risk than the average person, but much lower risk compared to other mutations in the BRCA1 gene. And so they're mentioning screening should be individualized based off of personal family history. I love that with HIS, but that should be history. So again, this is where meeting with someone specializing in genetics can help you understand what your risk is, what are your management recommendations, and tailor that to you and your family. So I'll end there, and if there's any questions, would be happy to answer them if we have time or offline as well. Thank you.
Thank you, Lauren.
Yeah,
Are there any questions from the group?
I have a question.
Yeah.
When you're talking about family history, are you mostly talking about like direct, like parents and grandparents, or how much do you include aunts, uncles, great aunts, uncles?
Yeah, so the models include more than that, especially the thyroid risk model will include, half half sisters, aunts, as well for breast ovarian cancer. There's also some other models out there which we're starting to explore using in our clinic as well that can take into account even more extensive family history. So while it doesn't always get inputted per se into the model, we still take that into account when we're looking at it, because we use models, but it might not be, if we're looking at something just seems even more significant than maybe what the model is putting out, we still have to use our clinical judgment and say, okay, well, this family really looks like there's hereditary risk. All the people in the family have had genetic testing who've had cancer. They're negative. We can't find anything, but this is just screaming like a BRCA mutation. We just feel like we can't find it. So then we might be making more significant screening and management recommendations for some individuals and families like that just really feel like we're missing something, Yeah, good question.
Other questions? I have one for you,
Yeah.
Lauren, on the polyvariant testing. Going back to your other slides, who would be a candidate? When I'm not sure I followed. When would you use that?
So for right now, the polygenic risk scores are really only clinically available for individuals who don't have that particular cancer themselves. So if you're doing it for breast cancer risk, you can't have a personal history of breast cancer. We're using it as a tool to help us better understand what their risk of breast cancer is and kind of incorporating that score into that thyroid-cusic risk model and having it as like another data point to say, okay, this is where we think your risk is. You should consider XYZ screening or other management recommendations based off of that. But we're not doing it in people who have, let's say, breast cancer themselves, and then using that to kind of change, anything that we're doing for them.
On the example you had earlier, on the two examples you had where their thyroid-cusic was very different, might you have used it given the family history on the one?
Sorry, say that again.
If you go back a few slides, you had those two examples.
Like these two? Yeah. Yeah. So this is is it where their family history and then they had different.
That one is high, but on the next one, might you incorporate it?
Yeah, exactly. So even, this would be a good one because maybe we're thinking, okay, they have some protective factors, but they still have family history, but their risk is, not enough to warrant screening. If we did a polygenic risk score for this individual and their PRS was like a 2.0, that's a significantly elevated risk. That would be then kind of incorporated back into this model, and it would push them up above that 20% threshold. Exactly. So we're definitely, offering it to individuals like this. There are some also disqualifiers depending on the lab. Like you can't have had a history of like a LCIS, for example, or I think sometimes like an atypical ductal hypoplasia. So there are some people we can't do it for, but for the most part, there's a lot of individuals who could benefit maybe from a polygenic risk score.
And then I have one final question for you. Since we are focused on cancer, we're thinking about cancer, but I know patients and I have had questions about other diseases that seem to run in the family. Do you and your team offer counseling for other diseases?
Yeah, that's a really good question. I didn't put this other individual on our team, which I should have. I was focusing more on our cancer team, but Marina is one of our newest genetic counselors who's joined us, and she's doing kind of all mostly non-cancer related indications. So people who have, cardiac diseases in the family, neurological diseases, hearing loss, kidney disease, kind of everything else is where she's focusing on. And so she's seeing patients at St. John's for that. So if there's other things that people are worried about their risk for, we would recommend they, maybe ask about referral to our team as well. And we can let them know that's an indication for a genetic counseling appointment. And we do have these polygenic risk scores for cardiac indications as well, things like type 2 diabetes, coronary artery disease, AFib. So there's single gene monogenic disorders as well for conditions if that's clinically indicated.
I guess my other question will be, do you run one test or multiple tests?
So it sort of depends.
Estimate-wise.
Yeah, so we try to sort of pick the best test for that individual, and that's why we do the counseling aspect of it first, because we try to figure out, is one test better for them to start? Maybe we get a really large hereditary cancer panel that we want to cover some rare genes on it because of their family history, but if that's negative, then maybe we separately do a polygenic risk score as a secondary test. Sometimes we can kind of integrate that all together on the front end, depending on if that's the most appropriate test for the patient. sometimes these polygenic risk scores, depending on the lab, might be an out-of-pocket cost if it's not integrated with a hereditary cancer panel. Again, costs have come down over time, so they're often in the range of kind of $200 to $300. Again, not available for everyone, but it's something that we discuss and offer.
Thank you. Mm-hmm. Any other questions? This was great, Lauren. I think you also, through this detail, really are sharing too how important it is to have genetic counseling, because one test doesn't meet all needs, nor does it make sense to the person who gets the results and has to have them interpreted in the context of what is going to be ongoing medical care. So thank you very much for being here today. For those of you on the call, if you'd like to see more of our health and wellness webinars, I think on the next slide, you can subscribe below on our YouTube site, and you could find our previous webinars in the Margie Petersen Breast Center, or we're also on Instagram at MPBC Breasties. And for more updates from Providence St. John's Cancer Institute, you can follow us on Facebook and LinkedIn at St. John's Cancer Institute. So thank you again for being here today. Hope to see you next month and or anytime on the web. Thank you.
Thank you, guys. Appreciate it.